The present topic of discussion, it is on blood disorders. It's the first part of blood disorders wherein we will be discussing about diseases of red blood cells, that is RBC disorders we'll be discussing here in this topic. So now let's move into the topic of discussion, disorders of red blood cells. Before going into discussing disorders, let's discuss some basic factors about red blood cells. Red blood cells, as we call it as RBCs or erythrocytes, basically they are of discoid shape or biconcave in shape and containing a basic protein called as hemoglobin. So this is a protein which gives that red color to the red blood cells, and that is a protein that helps in transport of oxygen to peripheral tissues. So what happens if there is a disorder of RBC? So these disorders of RBC, they are broadly categorized into two types, and mainly it will be in the form of anemias, that is different form of anemias it can be, where there will be decrease in RBC or decrease in hemoglobin concentration resulting in anemias. And the other disorder is polycythemia, which is in contrast to our anemias, wherein there will be increased level of RBCs will be seen. Now in this present topic of discussion, like we will be discussing on the whole about anemias, different types of anemias. Okay, so what is the definition of anemia? So there are different definitions which are given for anemia. Here we will be discussing two definitions, and we will see the first one. It is defined as reduction in the number of circulating red blood cells or quantity of hemoglobin and volume of packed red cells in a given unit of blood. So as the definition goes, there is reduction in the number of circulating red blood cells. So when there is decrease in RBCs, there will be decrease in hemoglobin also, resulting in anemia. And the second definition is, it is defined as reduction in the concentration of circulating hemoglobin or oxygen carrying capacity of the blood below the level that is expected for healthy persons of same age and sex of the individual. So here in this definition, what are they saying? There is a decrease or reduction in the hemoglobin. So as hemoglobin carries oxygen, so reduction in hemoglobin also reduces the oxygen carrying capacity, and there will be some values which are given for the hemoglobin for the same age and the same sex, that is for males and females. If it is going below that, then it is called as anemia. Now let's discuss the second the topic here, iron deficiency anemia, which is the commonest one and the most important one of types of anemia. So what happens in iron deficiency anemia is that, as I already told you, RBCs, they contain a basic protein called as hemoglobin, and this hemoglobin, it is made of globin, which is complexed with iron protoporphyrin complex, that is called as heme. So this globin and heme together is called as hemoglobin, and here the iron is present in ferrous state, Fe2 plus state. So this is responsible for that carrying of oxygen here, and this ferrous state of iron, it is present in hemoglobin, as well as it is also present in myoglobin also, which is said to be present in muscles, where it delivers oxygen as well as stores oxygen to muscles. And other than this hemoglobin and myoglobin, it is also present in some enzymes like cytochrome oxidase, where it helps in generating ATP for energy. So as we are discussing about iron deficiency anemia, let's see the forms of iron. So there in the body, there are two forms of iron. First is heme iron, which is present in ferrous state, that is Fe2 plus state. This heme iron is present in as a component of hemoglobin and myoglobin, and this heme iron is derived from animal products, and it is present in ferrous state, Fe2 plus state. And the other form of iron is non-heme iron, where this is present in ferric state, Fe3 plus state, and this is derived from plant products. So before saying about iron deficiency anemia, let's discuss how iron is obtained from diet and where it is absorbed and what is resulting in iron deficiency anemia. So let's talk about metabolism of iron. Most of the iron that is obtained from diet is absorbed in duodenal cells. So for example, take that this is a duodenal cell here. So like from diet, that is from animal products, if we take through diet, like then we get this heme iron, which is in the form of ferrous form of iron. Ferrous form of iron can be easily absorbed into the duodenal cell, whereas non-heme iron obtained from animal products, it is in ferric state, it cannot be absorbed into duodenal cell, so it has to reduce it to ferrous form. So what happens is that when diet enters the stomach, in the stomach, hydrochloric acid, it activates an enzyme called as ferric reductase. In the name itself it is there, ferric reductase. So it reduces the Fe3 plus to Fe2 plus, resulting in absorption of it into the duodenal cell. Once in the duodenal cell, it is stored as ferritin until its need arises. So as ferritin it gets stored. Now whenever there is a need, it gets transported out of the duodenal cell through transporter proteins like ferroportin and hephaestin. So after it enters out, after it goes outside, this iron, that is a ferrous form of iron in plasma or circulation, it cannot travel freely. So there has to be a carrier protein for ferrous in plasma, that is nothing but transferrin. So it transports iron to the needed sites, that is the target tissues. This is how metabolism of iron occurs. So in iron deficiency anemia, what happens is that this supply of iron is inadequate for the synthesis of hemoglobin. So as we have discussed the metabolism of iron, right? So from diet to target tissues, anywhere if there is a decreased supply of iron, that can result in iron deficiency anemia. So like where all how it can happen? First one is if there is loss from the body, increased blood loss can result, increased requirements or increased demand. So there are a few stages in the life wherein body requires more iron compared to the other stages. And inadequate dietary intake, if you don't take proper diet containing iron, then it can result in iron deficiency anemia. And if there is a defective absorption in the intestinal cell, that is duodenal cell, that can result in iron deficiency anemia. Now let's see what are all the various things that are causing, that are resulting in these causes. So etiology, wherein increased blood loss, it can happen because of excessive menstruation, repeated miscarriages, peptic ulcer, carcinoma of colon, hematuria, hemoglobinuria and hemoptysis. These are the various causes, various conditions wherein there is increased blood loss resulting in iron deficiency anemia. Next is increased requirements. So when our body needs more amount of iron, I told you there are various stages, right? What are those stages? When there is sudden increase in growth in the body, usually during spurts of growth in infancy, childhood and adolescence, there will be sudden growth in the body. And even during pregnancy, there is a need for this for both the mother and the fetus, and also during lactation. So when the demands are not met, that can result in iron deficiency anemia. And next is inadequate dietary intake. If you don't take in diet itself, so obviously it cannot get absorbed, it cannot go to target tissues. So whenever a person is in a poor economic status or anorexia or any elderly individual due to poor dentition, as there is poor dentition, they will not be able to take all the food they need. Okay, that can result again in iron deficiency anemia. And the last cause is decreased intestinal absorption. So that is within the duodenal cell, if it is not getting absorbed. When it can happen? It can happen either because of partial or total gastrectomy, or it can be by echlorhydria, wherein stomach HCl will not act, will not be there. So the ferric form of iron cannot be transformed to reduced to ferrous form. So then it will not be available for the circulation, right? Next, intestinal malabsorption cases in case of celiac disease. So these are the various etiological factors for iron deficiency anemia. Now seeing this, let's move into clinical features of iron deficiency anemia. So a clinical features, first, as it is anemia, generalized features of anemia will be there in any anemia. So what are the general features of anemia? Weakness, fatigue, dyspnea on exertion, palpitations, and you can see this pallor of skin, mucous membrane and sclerae. That is, there will be paleness in these areas. So whenever you visit a doctor, like whenever you have any features of anemia, they will see the tongue, they will see the eyes. Why? Because they are checking for anemia, whether there is any pallor or not. As you can see in the picture, usually conjunctiva will be red in color because of high vascularity, but here the person is exhibiting pallor. So these are features of anemia. As we are discussing iron deficiency anemia, there will be some epithelial changes also, and the first epithelial change is spoon shaped nails, which is nothing but koilonychia, as you can see in the picture. And next is there can be changes within the tongue, that is tongue can become smooth, red and painful because of the atrophy of the filiform and fungiform papillae. That condition is called as atrophic glossitis. And within, as an oral manifestation, there can be another feature also, which is nothing but angular cheilitis, wherein there will be cracks or fissures at the corner of the mouth. As you can see in this picture, there are these cracks which are seen in the corner of the mouth. This condition is called as angular cheilitis or angular stomatitis. Other than these symptoms, there can be esophageal webs or strictures which can result in dysphagia, that is difficulty in swallowing. As esophageal webs occur, obviously the difficulty in swallowing will be there. Why there will be these webs or strictures in esophagus is because as it is iron deficiency, so here depletion of iron dependent oxidative enzymes will be there, which are needed for the muscles. As iron is not there, it can result in myasthenic changes in the muscles that results in these strictures within the esophagus that causes dysphagia. And next symptom is post-cricoid carcinoma. So if you see this koilonychia, atrophic glossitis, dysphagia, post-cricoid carcinoma, all these together with iron deficiency anemia results in a syndrome called as Plummer-Vinson syndrome, which is a characteristic feature of iron deficiency anemia with these symptoms. So these are about clinical features of iron deficiency anemia. Now let's move into laboratory diagnosis, that is laboratory findings. Any anemia, first we will be seeing the blood picture and red cell indices, because it is anemia, right? So there will be changes in red blood cells. So as it is an anemia, definitely there will be decrease in the hemoglobin concentration. Usually hemoglobin will be more, has to be more than 12 in either males or females, but here it will be as low as below 6 gram per dl. And if you make a peripheral smear and see, like here, as you can see, all those are red blood cells, where you can see that central pallor, that is nothing but hypochromia of the red blood cells. Usually hemoglobin gets dispersed within the red blood cell. Here hemoglobin is very less, resulting in the central pallor, that is nothing but hypochromic. And the cells also will be smaller in size, that is called as microcytic. So the type of anemia that is seen in iron deficiency anemia is hypochromic microcytic anemia. And the absolute values like MCV, MCH, MCHC, that is mean corpuscular hemoglobin, mean corpuscular volume, mean corpuscular hemoglobin concentration, all the three values will be decreased in case of iron deficiency anemia. Why? Because hemoglobin concentration is low and cellular size is low. As both are low, obviously hemoglobin concentration also will be low. So this is about absolute values. Now if we take a bone marrow aspirate and check, what will be the findings? There will be marrow cellularity, which will be increased. The marrow cellularity will be increased because of the erythroid hyperplasia. Why? Because as there is anemia, as a compensatory mechanism, the bone marrow will try to produce more and more red blood cells to increase the hemoglobin concentration, because of which there will be erythroid hyperplasia and increased marrow cellularity. And the erythropoiesis will be normoblastic only in bone marrow. Next we can even do biochemical tests to check for iron. So as this is iron deficiency anemia, obviously serum iron concentration will be very low and the total iron binding capacity, that is TIBC, will be increased. And next, the serum ferritin concentration. Serum ferritin is a storage form of iron. So obviously storage form of iron also will be low as this is a deficiency. And serum transferrin receptor protein will be increased because the transferrin, like as there is no iron, the transferrin will be freely flowing within the serum itself. Okay, so there will be concentration of the serum transferrin receptor protein which will be increased. So this is about iron deficiency anemia. Now let's move into the next type of anemia which is also very important, that is megaloblastic anemia. So what happens in megaloblastic anemia? So name megalo, that is big, right? So here both the erythroid precursors as well as RBCs, they will be abnormally large. Why the RBCs and its precursors will be large? Precursors are nothing but pre-erythroblasts, normoblasts and all that, okay? So everything will be abnormally large. Why? Because of the defective cell maturation as well as cell division. Why there will be defective cell maturation and cell division is because of the delay in the maturation of the nucleus relative to that of the cytoplasm. So the maturation of the nucleus of these erythroid precursors will be defective, resulting in megaloblast. So what is making all these changes in the erythroid precursors as well as RBCs? So that is about etiology. So it is because of the deficiency of few important vitamins, that is one is folic acid deficiency or folate deficiency and also vitamin B12 deficiency. So combination of these two will result in megaloblastic anemia. Sometimes only vitamin B12 deficiency occurs, resulting in a separate anemia called as pernicious anemia. So now saying that, we shall discuss what is the role of folic acid and what is the role of vitamin B12. First of all, that can cause changes within the nucleus of erythroid precursors. So folic acid is also called as tetrahydrofolate, wherein the main function of it is to transfer 1 carbon moieties. So what are these 1 carbon moieties? Are usually formyl and methyl groups. What does these formyl and methyl groups, that is 1 carbon moieties, do is they help in synthesis of various proteins that are needed for the synthesis of DNA, like purine synthesis. Purines, they are part of DNA, and also helps in the conversion of homocysteine to methionine, and also helps in the synthesis of deoxythymidylate monophosphate synthesis also. So all the three, that is purine, homocysteine to methionine and this deoxythymethylate, all these are helpful in the synthesis of DNA. Okay, so this is when folic acid is normal and helping in transfer of 1 carbon moieties. But if at all this folic acid is deficient, the synthesis of DNA will become defective. So there will be defective DNA replication, that is resulting in formation of megaloblasts. So this is one role of folic acid and what happens if there is a deficiency of folic acid. Now let's move into vitamin B12 role. So vitamin B12, which is also called as cyanocobalamin, it is obtained from the animal products like eggs or dairy products like milk and milk products. So usually any deficiency, it will be most commonly seen in strict vegetarians because they doesn't take animal products. So whenever vitamin B12 it is taken through food, it enters the stomach. So there vitamin B12 cannot roam freely. So this vitamin B12 it complexes with a protein called as R binder, and with the help of R binder only it enters duodenum, wherein duodenum vitamin B12 will become free and this R binder will become digested. So now that vitamin B12 is free, but the absorption of vitamin B12 occurs at ileum only. Only from there it can be taken to circulation and everywhere. But how does it has to reach ileum is with the help of intrinsic factor which is secreted by parietal cells of stomach. So this intrinsic factor, it complexes with vitamin B12 and it carries to distal ileum. So where in the distal ileum this vitamin B12 will be absorbed. So once the absorption of vitamin B12 occurs, what happens to intrinsic factor is that it gets destroyed. So intrinsic factor is destroyed. Now that we have this vitamin B12 which is free in form, now it has to like whenever there is a need, it will enter the circulation. So it the transport protein of vitamin B12 to circulation is transcobalamin 2. So vitamin B12 complexes with transcobalamin 2 and enters the circulation, and from there it goes to liver, bone marrow and the cells whichever need vitamin B12, it moves there. So this is about metabolism of vitamin B12. But how it helps folate is that it helps in conversion of this homocysteine to methionine reaction that helps in folic acid formation. So whenever vitamin B12 is deficient, it helps in trapping of the folic acid as non-functional tetrahydrofolate. So tetrahydrofolate, as we know, they help in transfer of one carbon moieties that helps in synthesis of DNA. If folate is getting trapped because of vitamin B12 deficiency, definitely again there will be defect in the DNA synthesis resulting in megaloblastic anemia. And previously I told you something about pernicious anemia, right? So where in this vitamin B12 this pernicious anemia occurs is near intrinsic factors. It is actually an autoimmune reaction against parietal cells of the stomach as well as intrinsic factor itself, resulting in gastric mucosal atrophy wherein there is reduced intrinsic factor secretion. If intrinsic factor is not there, vitamin B12 does not get absorbed. So as vitamin B12 is not absorbed, so it results in again other symptoms giving rise to pernicious anemia. So this is about role of folic acid and role of vitamin B12 in megaloblastic anemia and pernicious anemia. Now let's move into clinical features of these. Here pernicious anemia, it is also called by other names like primary anemia, Addison's anemia and Biermer's anemia. So firstly, as this is anemia, we will see general features like dizziness, weakness, fatigue and a pallor of skin, mucous membrane as well as sclera. All these general features of anemia are observed. And other than this, because of folic acid deficiency and vitamin B12 deficiency, there are some neurological manifestations also which can be seen. So these neurological manifestations are because of the degeneration of the posterior and lateral tracts of spinal cord, as well as degeneration of myelin sheaths, as well as degeneration of peripheral nerves. What all this nerve degeneration will do is it can cause paresthesia of the extremities as well as general irritability and loss of vibratory sensation or incoordination within the body. So too many neurological manifestations are seen because of the deficiency of these two vitamins. And there can be some oral manifestations also. There will be features on the tongue that is called as Hunter's glossitis or Moeller's glossitis. What happens here is that there will be atrophy of the papillae of the tongue and the tongue becomes bald. And this kind of tongue in megaloblastic anemia or pernicious anemia is called as fiery red tongue or beefy red tongue. And the tongue also exhibits glossitis, that is inflammation, glossodynia, that is painful tongue, and glossopyrosis, that is burning sensation of the tongue. As I told you, beefy red tongue, it will be painful and burning sensation of the tongue. And the oral cavity, it also shows some small shallow ulcers resembling aphthous ulcers. So these are the various clinical features that are seen in pernicious anemia as well as megaloblastic anemia. Now let's look into the laboratory findings. So as this is anemia, we shall see a blood picture and red blood cell indices. So obviously anemia, right? So hemoglobin will be moderately low here. And the red blood cells, as I told you, these are abnormally large. So here the red blood cells will be macrocytic, that is cellular size will be bigger, macrocytic in nature. And along with that, if you take a peripheral smear, you can see features like stippled cells, nucleated RBCs. Usually RBCs will not be nucleated, only its precursors are nucleated. And we can see Howell Jolly bodies which contain basophilic nuclear remnants, and cabot rings wherein thread-like strands will be seen in RBCs. So if we see a peripheral smear, so this is a peripheral smear wherein all those are RBCs and there is a rounded cell, right? As you can see, there are blue dots, that is nothing but stippled RBCs. And in the second picture, as you can see, these RBCs contain one blue dot at the periphery in few cells. Those are nothing but Howell Jolly bodies, which are the nuclear remnants that are seen in RBC. And what happens to these absolute values MCV, MCH and all? Cellular size is increased, so MCV is increased, and as it is a mean corpuscular hemoglobin, so according to the cell size, if we take hemoglobin concentration, it will be elevated only. And what will be the serum analysis, that is biochemical analysis? As there is vitamin deficiency, there will be low serum vitamin B12, and as it is an autoimmune reaction, that is pernicious anemia, there will be antibodies to intrinsic factor, and there will be increase in serum lactic dehydrogenase, as well as some minerals like potassium and cholesterol, and skeletal alkaline phosphatase levels in the serum will be decreased. So these are the various laboratory findings in megaloblastic anemia. Now let's look into another different type of anemia which is very important, that is thalassemia. What happens here? This is actually a hereditary disease wherein there will be reduced synthesis of globin chains. So globin is a part of hemoglobin, right? So if you see here, this is the basic structure of a hemoglobin wherein it contains 2 alpha and 2 beta globin chains. So where these 2 alpha and 2 beta chains, they are produced by their respective genes. So if at all there is a deletion in the genes coding for these globin chains, that results in thalassemia. So there are 2 types of thalassemia here. So if at all there is a deletion in the alpha gene coding for alpha globin chains, then it is called as alpha thalassemia. And if at all there is a deletion in the beta genes coding for beta globin chains, then it is beta thalassemia. If you see in alpha thalassemia, this is these 2 are the chromosomes which are derived from mother and father, and alpha genes are present on chromosome 16. As you can see, on each chromosome there are 2 genes. So one alpha globin chain is coded by 2 genes. That means 2 alpha chains are controlled by 4 alpha genes, right? So the mutation in these 4 alpha genes, so that can be in the form of deletion here. So what happens is, if at all out of 4, if only 1 alpha gene is deleted, then it is called as alpha thalassemia trait. That means the person with this trait will not show any symptoms, but he or she has the tendency to transfer it to their offsprings. And if at all 2 alpha genes are deleted, that also results in trait only. Whereas 3 alpha genes are deleted, then it results in HbH or hemoglobin H disease, where this H represents Heinz bodies. And if all the 4 genes are deleted, then it results in a severe form called as HB Bart's hydrops fetalis. So these are the various types of alpha thalassemia. And if you see beta thalassemia, that is present, the genes present on chromosome 11, and there will be one beta globin chain is controlled by 1 gene only. So 2 beta chains, they are controlled by 2 genes. So here what happens is that the 2 beta globin chains controlled by 2 genes, here also the mutation occurs at a transcription and translation level. So if the mutation is at the transcription levels, that is if there is a transcription defect, then it results in reduced synthesis of beta chain. That here there will be only reduced synthesis but not complete absence. Only reduced synthesis of beta chain will occur. That is called as beta plus thalassemia. Beta positive or beta plus, in either way you can call, beta plus thalassemia. Or if the defect is in the translation, translation defect, that results in no synthesis of beta chain. Beta chain itself will not form. So no synthesis of beta chain, that is called as beta 0 thalassemia. So based on this, that is beta 0 and beta plus thalassemia, there are four forms of beta thalassemia. That is, first one is beta thalassemia minor, which is a heterozygous state. That is beta positive from one patient and one parent, and beta 0 from one parent are transferred to the offspring. Next one is beta thalassemia intermedia, wherein both the parents transfer only beta positive. Whereas beta thalassemia major, it is a homozygous form wherein there will be no synthesis of beta chain, that is beta 0 it will be. So this is a severe form. So these are the various forms of beta thalassemia. Now that we have seen different types of thalassemia, we shall see clinical features. So first is HB Bart's hydrops fetalis. While telling only, I was talking that it is very severe form, as these globin chains are the ones which has to transfer oxygen, right? So as all the 4 alpha genes are deleted in HB Bart's, so the child which is born will be incompatible with life due to severe tissue hypoxia, that is lack of oxygen. So the infant dies shortly after birth itself. So it's a very severe form. And next is HBH disease, wherein I told you the H is it is precipitated as Haynes bodies within the affected red blood cells, and the symptoms will be in the form of severity of anemia, splenomegaly and cholelithiasis. Whereas in case of beta thalassemia major, symptoms like anemia, hepatosplenomegaly, extramedullary hematopoiesis and iron overload can be seen. And the main feature of beta thalassemia is that there will be bone changes that are seen because of the hematopoiesis. Okay, so these bone changes can result in disfigurement of the body, that results in thalassemic faces and malocclusion of the jaw. So the kind of features that are seen here are mangaloid features, where there will be prominence of the cheekbones, flaring of the anterior teeth and depression of the nasal bridge. So these are the various features that are seen in beta thalassemia major. As there are changes within the bones, we can even see the radiographic features. So here the characteristic radiographic feature that is seen in thalassemia is hair on end appearance of the skull. So like if you take a lateral skull radiograph and check for the you can see in this picture, wherein the inner and outer cortical plates of the skull, they are very much poorly defined. Only the intervening trabeculae between plates are elongated, resulting in that hair on end appearance. And this kind of appearance is also called as crew cut appearance also. It's like small hair on the skull. Okay, and there is one more feature called as salt and pepper effect because of the coarsening of the trabeculae of the bone. So these two are important features, important radiographic features of thalassemia. Now let's see laboratory findings like other ones. So as this is a type of anemia only, we will see features in red blood cells. Here also the type of feature that is seen in red blood cells is hypochromic, that is because of lack of hemoglobin, and microcytic because cells will be smaller. And the RBCs here, they exhibit poikilocytosis and anisocytosis. And if we see in the peripheral smear, the RBCs will be in the form of target cells. So this target cell is nothing but the hemoglobin, whatever is present, it gets condensed in the center. The coloring matter will be in the center, resulting in the peripheral paleness. As you can see in this picture, this is a peripheral smear of thalassemia, wherein those cells which are pointed, those are target cells. As you can see, some coloring matter is deposited in the center, resulting in target cells. Other than target cells, we can even see safety pin cells or nucleated RBCs here in thalassemia. And if you see absolute values, MCV, MCH and MCHC, like in iron deficiency anemia, all are reduced. And the other features like leukocytes, there will be leukocytosis. normal value of leukocytes will be 4,000 to 11,000, whereas here it increases from 10,000 to 25,000. And also bone marrow shows hypoplasia indicating maturing arrest, as well as there will be breakdown of these cells so much, because of which there will be increased serum bilirubin. As there is breakdown, we can even see hemosiderosis also. So these are the various laboratory findings that are seen in thalassemia. Now let's move into the next type of anemia. This is also important, which is sickle cell anemia. Here also this is a hereditary disease wherein the changes seen in RBCs are upon exposure to low oxygen tension, that is deoxygenation. It results in sickling, that is the basic normal red blood cell shape of discoid or biconcave shape will turn into sickle shaped, as you can see in the picture. Why does it occur? Why does this sickling occurs on deoxygenation to RBC? As I already told you, it's a hereditary disease, so there has to be some mutation somewhere. So the type of mutation here is a point mutation at one single area. So this is single point mutation. So basically hemoglobin, it is made of amino acids, right? So amino acids are coded by some nucleotides. So here the CTC codon is changed to CAC codon. So that point mutation occurs in thiamine, which is replaced by adenine here. So basically this CTC codes for glutamic acid and CAC codes for valine. So now that valine is replacing the glutamic acid because of that point mutation at a position called as 6th position on the beta globin chain. So now this is changing the hemoglobin structure itself, right? So this kind of hemoglobin is called as sickled hemoglobin here. So valine is replacing the glutamic acid because of point mutation. So this sickled hemoglobin, upon deoxygenation, what will happen is there will be polymerization inside the red blood cell to elongated rod-like polymers. So these rod-like polymers make the changes the biconcave shape of the RBC, resulting in sickle-shaped RBCs. So basically this sickle shape of RBCs can be reversible to normal biconcave disc-shaped RBCs upon reoxygenation. That is, upon oxygenation again, they can undergo reversible to normal red blood cell, provided that the membrane is not damaged. So now this sickle shaped RBCs, like they are reversible, it can become irreversible also. When it can be reversible, like I told you, whenever the membrane of this RBCs is damaged, they will become irreversible sickle shaped RBCs. As you can see in this picture, this is a irreversible sickle cell because the membrane is all damaged. So this is the basic pathogenesis of sickle cell anemia, how it occurs. Now let's see clinical features of sickle cell anemia. So here also we see a heterozygous state and a homozygous state. In heterozygous state, what happens is that the abnormal gene is inherited from only one parent. So that results in sickle cell trait wherein there will not be any significant clinical problems, only hypoxia, mild hypoxia can be seen. Whereas homozygous state wherein abnormal gene is inherited from both the parents, resulting in sickle cell anemia. So it gives all the main clinical manifestations and decreased life expectancy also. So here we will see general features of anemia. Along with that, we see pain in joints, limbs and abdomen. Why? Because of the infarcts, macro infarcts. Why this infarcts occur is because of the vaso-occlusion. Why vaso-occlusion is that this capillary blood capillaries, they are obstructed by this sickle shaped RBCs. Normal biconcave RBCs, they tend to move around very easily, taking oxygen everywhere. But here these sickle shaped RBCs will be very much brittle that they cannot move and they infarct the blood vessels, obstruct the blood vessels. And the other symptoms other than pain are nausea and vomiting, systolic murmur and cardiomegaly. And like I told you, it obstructs the blood vessels. So it doesn't take oxygen everywhere. So packing of red blood cells in peripheral vessels with erythrostasis and also local tissue anoxia. That means local tissues doesn't get enough oxygen. So what will be the radiographic features here is that it will be similar to thalassemia, that is hair on end pattern can be seen on the skull radiograph. there can be generalized osteoporosis, and long bones, they show enlarged bone marrow cavity with thin cortices. So these are the various radiographic features that are seen in sickle cell anemia. And now we'll see laboratory findings of sickle cell anemia. So as this is anemia, so here the hemoglobin concentration will be low to a level of 6 to 9 gram per dl. And if we take a peripheral smear of the blood of the sickle cell anemia patient, we tend to see numerous sickle cells. As you can see in this picture, 2 to 3 sickle cells are there. Along with that, if you see other RBCs, they are more like target cells which are seen in thalassemia, right? That is, the central chromicity is there because of the hemoglobin accumulation in the center. So the blood film shows sickle cells as well as target cells. And there is a test for sickle cell anemia, that is sickling test, wherein the erythrocytes are treated with reducing substance such as sodium metabisulfite. If the individual is with sickle cell anemia, then he shows a positive sickling test. So this is in detail about sickle cell anemia and also the most important anemias in general. So here, like in writing about features and the laboratory findings will be very easy. And here all the 4 different types of anemia, like they are very much like in the exam point of view, they can come as essays as well as individual laboratory findings or clinical features. They can come as short note.